we are ruling out life threats in emergency medicine. So you guys will have seen most of the chief complaints or most of the disease processes that we're going to be talking about in this class. But now we're going to teach you how to emergently manage them, stabilize and transfer, basically. So instead of definitive management, sometimes instead of even definitive diagnosis, you are going to be ruling out life threats and emergently acutely stabilizing for transfer. Does that make sense? Okay, so basically each chief complaint or each problem that somebody comes in with has a list of sort of life-threatening or emergent possibilities, and your goal is to make that list and then figure out what you need to do to rule those things out or to stabilize that. That's where, for example, the differential diagnosing pocketbook comes in handy, or basically just kind of like having an ever-revolving list of your top kind of life threats that you want to make sure that you rule out. Okay? Emergency medicine, we are Jacks or Jills of all trades. So we do just a little bit of everything, not a lot of things. And it's also an amazing opportunity for procedures. I like live, breathe, cry procedures. I love procedures. They're my favorite thing in the world. So emergency medicine is heaven to me. I love being able to do that many procedures. The only time I ever got to do more procedures was in the ICU. And that was like central lines and patients and stuff like that. You also have an opportunity to do resuscitation, to learn how a code looks, how a full code, how a mega code looks, and often to participate in that, to do compressions and to help run one of those codes. And also for some of you who do the trauma surgery rotation, you'll get to run trauma codes as well. It can be a very intense experience. You need to be aware of your surroundings at all times. Your personal safety and your personal health are always your very first priorities in the emergency room in particular. So what I mean by that is not only like your safety in relation to those around you. So never put yourself between a patient and the door, regardless of how nice or kind you think they are. But also things like your body. So your body mechanics. You only get one back, and you only get 2 feet. So use them wisely. If you're doing like sutures and stuff like that, make the bed come to you, make the patient come to you. Don't be leaning over, like doing like delicate sutures or like operations like way over here. Make that come to you so that you're comfortable and you're not bending in a weird way that's gonna screw you up later. Make sure you hydrate, make sure that you eat, even if it may seem impossible. These are all things that are really important in the emergency room. So, anybody know who Bissell guy is?
Berenstein Bear?
What?
Is that a Berenstein Bear?
No.
Oh.
I don't expect you to know the books that I forgot, but it used to be called the Scut Monkey's Handbook. Now it's called the Clinician's Pocket Guide to being a good student or something like that. But this is our little friend, Scut Monkey. So anatomy of a good emergency medicine student. So when you guys go on rotations, these are some things that you can do to make your life a little bit easier in the emergency room. You want to stay on top of your patients and their results. This is one of the most valuable things that you can do when you're building a relationship with your preceptor, is to be aware of how many patients you have, where they all are, and what's going on with them. What is holding you back from kind of moving them on to the next step? Are you waiting on a CBC? Are you waiting on a preg test? Are you waiting on results of a CT scan? What are you waiting on for each one of those patients for the next step in management? Always know your kind of ER standard procedures. This is protocol based, so your ACLS, your PALS, that kind of thing, ATLS, which we're going to learn a little bit about in this class, and you guys are also taking ACLS and PALS before you go on your rotations. So not only is it those type of protocols, but also how does each emergency room function? Who occupies what roles? Who do you turn to for various asks or requests? And what can you do to kind of make those people's lives easier and thus make your own life easier, okay? One of the most important things is nobody's your mama in the ER. Clean up after yourself. So if you do sutures, put all your sharps away. And not only do you put all your sharps away, you clean up the room after yourself. So you put away your suture kit, you throw away your suture kit, you pull apart all your sharps and either put them in the sharps container or back in the autoclave rotation. And you clean everything up so that nobody else has to do that for you, right? Same thing whenever you're rotating patients through rooms. If you've got a little extra time and you want to help kind of clean up the room a little, that's also totally fine. Be nice to nurses, always be nice to nurses, but especially in the emergency room, they will eat you alive if you're not nice to them. But that should be pretty much second nature to you guys, right? Like you ask nicely for things, you take into consideration how the flow of the emergency room is going. Are they all being diverted to a big code? Probably not the time to ask them for, where the water machine is or something like that, right? Be sensitive to your surroundings, to what's going on in the emergency room. And then that's the last one too, be sensitive to good and bad times to ask questions. So in the middle of a mega code, probably not a great time to be like, I have a question about like resuscitation. Try to save up your questions for a time when the preceptors, they want to help you, they want to inform you of things. The more that you can kind of understand the flow of like what's happening in the emergency room, the better education you're going to be able to get. Does that make sense? Yeah. Any questions about any of that? Okay. And then last, these are some emergency medicine reminders. For many, the emergency room is the only place that they can obtain care. So we have a shortage of primary care and primary care education in this country. So many people turn to the emergency room for problems that you might not turn to the emergency room for, or that your friends and family might not turn to the emergency room for. This does not make it not an emergency. You still take care of them the same way you would every single other person. Many patients in the emergency room, we know this, have underlying social, psychological, and substance abuse issues. Not all of them, but some of them do. So it is a little sympathy can go a long way. A little patience can go even longer. A little dignity is the best gift that you can give somebody. And every patient deserves a thorough history and physical, no matter how difficult or smelly or challenging it is. So those are your reminders for emergency medicine, okay? Especially those who are going to kind of urban underserved areas like Cal. There will be a lot of smelly, challenging, difficult patients, and they deserve the same chances that the nice old lady in 3 deserves, right? Okay, let's talk about trauma. Advanced trauma, ATLS, Advanced Trauma Life Support. So Advanced Trauma Life Support is a full class that you can take. So we're going to give you kind of the primer, the basics on ATLS, so you guys have an understanding of sort of how trauma flows in the emergency room. The first thing we're going to talk about is the golden hour of trauma. The golden hour of trauma is the period immediately following the incident of trauma. So as soon as the trauma happens, the clock starts on that hour. So this is including pre-hospital time. This is including time for discovery. So if they have like a prolonged extrication period, if I've seen people where they like ran off the road at like 3 a.m. and they weren't discovered till the next morning. Well, that golden hour is way long gone, right? So all of those things, as soon as that trauma happens, that clock starts ticking. But this is the period in which you have the greatest success of assessment, diagnosis, and stabilization of acute trauma, okay? So I'm gonna kind of take you basically through a trauma code over the next couple of slides. I'm gonna tell you like what I do or what I say when I'm running a trauma code, so you guys kind of have an understanding of how these things sort of flow through. I always say I have a patient in front of me, and it's gonna be a little slower because I'm explaining things at the same time, but this is kind of the general idea. So, yeah.
So it's the first hour, golden hour, the first hour after the trauma happens.
Yep, boom, trauma happens for 60 minutes afterwards. That's your best opportunity for resuscitation. So, like I said, if they have like, we don't deal with this as much here in Los Angeles County, but in many places, it's longer than an hour to get to a trauma center. The closest trauma center, the closest trauma receiving center. So, like, you may run out of that time. That doesn't necessarily mean the person's gonna die, but the more severe the trauma is, the sooner you guys can get them in, the sooner that we can start diagnosing and treating them, the much better chances they have of a meaningful recovery. So, prior to patient arrival, what happens is some sort of like tones go off, pagers ring, trauma code is activated. Usually that comes from EMS calling it in. So they call into the trauma center, they say, we have this, and this coming in. The nurse receives the report, acknowledges it, and activates the trauma team. And so that can vary depending on your location, but most of the time it's gonna be like a standard set of people that are arriving at the bedside that get deployed no matter what kind of trauma it is. So that would be the trauma surgeon, likely some trauma advanced care provider, so either like a PA or an NP, pharmacy, radiology, and between 3 and 4 like nurses and techs that are going to be helping with run the trauma code. That's like minimum, bare minimum, okay? And we gown up, glove up, face shields are on, or protective eyewear of some kind. What are standard precautions? Yeah, so basically what I just said, right? Gown up, glove up, and you need to protect your eyes. And then we do a team debrief. So once everybody is here, once everybody's like on in the trauma bay, we do a team debrief. Mine usually sounds something like this. So, hello, trauma team. What we know is that we have an approximately 40-year-old male who was struck by a vehicle. He's GCS 14, paramedics on scene, and is complaining of pelvic pain and trouble breathing. When the medics get here, we will have a moment of complete silence from all team members to allow the paramedics to give us their best information. Then I will be doing the primary and secondary survey and calling out my findings. I would like to have the following: chest tubes available on either side of the bed, a pelvic binder available, the rapid infuser ready to go. Who is establishing IV access? And then we wait for a response and somebody identifies themselves as being like the IV person. Who is taking vital signs and putting the patient on the monitor? Most of the time that'll be the ER tech or the trauma tech. And do we have pharmacy available? Pharmacy will raise their hand. X-ray will raise their hand. Okay, thank you everybody. And then that concludes kind of the trauma debrief. This gives out the chance for the team, the whole team, to be on the same page. We know what I'm suspecting. You know, the person's been struck by a car at, approximately maybe 40 miles per hour. So we know there's a likelihood of internal injuries. We know that there's likely chest, abdomen, maybe pelvis, considering that he's a fully grown adult who was struck by a vehicle, right? So it's gonna strike approximately here. Make sense so far? Okay. Oh yeah, this includes the
Question.
okay, yeah.
You said G something, what does that mean?
We're gonna get into it.
Oh.
Yeah, so none of this is like the only time you're gonna hear this. This is just like, remember we talked about like doing passes of information in PA school. You hear it once, you hear it twice, you hear it 3 times kind of thing. So GCS is, we're gonna break it down much further later in the slide deck, okay? Everything make sense so far?
Mhm.
Okay. So, in trauma, as in like ACLS, everything is corrected immediately. So if you have an abnormal finding anywhere in the primary or secondary survey, you're correcting it immediately. So the primary survey is going to be our ABCDE, just like it is in like ordinary assessment. What's the A stand for?
Airway.
Oh, I did it all, darn it. Okay, so airway and cervical spine precautions in trauma. We are always thinking about cervical spine injuries in trauma.
Sorry,
The-
quick question. Are we
yeah.
gonna have this?
Yeah,
Okay.
yeah, but we are encouraging active learning now. So you guys will get the updated PowerPoints when the class is over. But this gives you an opportunity to kind of think about like what you've read and everything before you have it right there in front of you.
No, I just wanted to know how.
It's in the
fast
slides.
Yeah, no, you'll get this updated
Each one.
slide deck. Same with like every other class that I teach. It'll come out after we finish the lecture. So B is going to be breathing and ventilation. C is circulation and control of hemorrhage. So we always talk about hemorrhage and trauma and where it could be coming from. D is disability. So we're going to talk about neurologic status. And E is exposure and environmental control, including hypothermia. Any abnormal findings corrected immediately. So, airway. We are going to assume C-spine injury in trauma patients until proven otherwise. How do we prove otherwise? Imaging. Imaging is the only definitive way to prove that they do not have a C-spine injury, especially in the initial assessment. So now there is like nexus criteria, things like that we'll get into, that you may be able to use if the patient is not otherwise distracted or obtunded. But in the primary survey, the only thing that will suffice is imaging. And so since we are not doing imaging, we are assuming C-spine injury until proven otherwise. Then we're going to assess patency of airway. This is basically the same as like any other patient. There's nothing really that changes. What I say when the patient comes in, as soon as they get plopped down on my table, I say, "Hi, what's your name?" They can answer me. Do they have an airway?
Yeah.
They have an airway. And then I say, do you remember what happened? And then if they can tell me, oh yeah, I was in a car accident, then you cut them off nicely, because then a lot of times they have like another 10 minutes to tell you about the stupid person that just cut them off. So as long as they can tell you, they can remember, they have recall, you basically establish alert and oriented, right? That is, can you give me a thumbs up on your right hand? Give me a thumbs up. They can do that, they've got motor control, they're following commands. Boom, 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 right? Hi, my name's Katie, I'm with the trauma team. A lot of things are gonna be happening all at once, and we're gonna check you out head to toe. And then I call out for my trauma team. I say airway intact, alert and oriented ×3, GCS 15 or GCS 14 or whatever it is. And we're gonna break GCS down again in a minute. If the patient is at all obtunded, meaning they are at all altered, they are likely gonna get intubated. If it's a GCS 8 or below, you intubate. GCS 8, intubate, okay? And we're gonna, like I said, we'll get GCS for you. If the patient arrives and is already intubated, we need to confirm ET tube placement. How do we confirm ET tube placement?
X-ray.
Very good. So can we do it by auscultation? Can we do it by auscultation? Who says yes? Raise your hand if you say yes. Okay. What about no? You can't confirm ET placement by auscultation. Who says no? Raise your hand. Hi, come on, take a chance. You're doing this, but you got a 50% chance.
So I think it's
Right, well, so X-ray and or end-tidal CO2 is the only way to confirm ET placement because it doesn't involve objective or subjective measurements, meaning like you're not listening to their lungs and thinking that you hear breath sounds and you don't. Make sense? End-tidal CO2 monitoring. That and or X-ray is now the new gold standard of confirming ET tube placement. I just restarted ACLS, so I'm all like, yes, I got all this information. Okay, I think that's it. Any questions on airway? I see a lot of faces out here that are like, oh my God, I'm never gonna make it through this class. Keep in mind that this is not the only time that you're gonna see any of this. So you're gonna see each system again. We're gonna go into more depth. This is just kind of like a broad overview of trauma and emergency room, okay? Yeah. I promise you you're gonna be okay. Okay, breathing and ventilation. Again, not much different. We're gonna do auscultation. We're not flipping them yet. So we're basically doing auscultation at 3 points on each side of the front of the anterior aspect of the chest. Take a deep breath. Take a deep breath. Take a deep breath. You know, take another one. Take another one. Take another one. And then once they're done with that, then you call it out for the trauma team. So bilateral breath sounds intact, no wheezing, bronchi, or rales. And then if there is any of those things, then obviously you're not calling out a normal finding, right? And if there is anything that you are unsure of, like for example, if you go do a trauma rotation at Dr. Shepherd's House of Trauma down at St. Francis, and you're doing this initial assessment and you're like, dang, I don't know, I'm not really sure, I can't really hear breath sounds, say you can't really hear breath sounds, okay? There's no shame. Sometimes I can't hear them. Sometimes I confirm with a trauma surgeon or another one of the providers. It's loud, it's chaotic, patients aren't cooperative. It's okay to not be sure, all right? You don't have to be absolutely positive about everything. Okay, circulation and hemorrhage control. So we're gonna make sure we have 2 large bore IVs, that's 14 or 16 gauge. We're looking at capillary refill, pulse, skin color, right? We're getting them on the monitor. We're doing life-threatening hemorrhage control with direct pressure. And if you have a suspected pelvic fracture or you have like an unstable pelvis, then a pelvic binder can be applied at this stage, but we can also do it when we flip them and roll them and be able to put the binder on underneath. And we will tell you, there will be some more slides about what a pelvic binder is and other things like that, so don't worry. And then we're assessing central circulation here. So we need to assess femoral pulses, not just radial pulses, we need to assess central circulation as well. So with control of hemorrhage, direct pressure is kind of the gold standard. Occasionally you'll see like clamping or tying off of like obviously hemorrhaging vessels, if you can see them inside like a wound bed. Or like scalp lacerations are famous for having like little spurters, like you lift up like the flap and you like a little arterial arc comes out. So sometimes they will, right there, like at sea, control, like clamp off and tie a small bleeder. That won't fall to you, especially as a student, but it is something that's occasionally done. However, you are not blind clamping, you're not fishing around inside of wound beds with like hemostats, trying to find bleeders. This is not the stage for that kind of thing. That's where direct pressure is going to be your best bet, okay? Central circulation intact, 2+ femoral pulses, IV access, left and right AC, 16 gauge. Disability. So this is where we get into our Glasgow Coma scale, alert and oriented. So we know alert and oriented, right? Times 3 or times 4. So what are the 4 parts of ANO? Person. That's GCS. Hold that thought. Alert and oriented. So person,
place,
time, an event, or like event is really what purpose. Yeah, exactly. Whatever you can use, like why are you here? You can use what happened to you in trauma. What happened works pretty well because people are like, oh my God, you wouldn't believe what just happened to me. This guy just came out of nowhere, and you're like, okay, thank you very much. That's all I need. Okay. And then this is also your chance for pupillary response. So give them a quick flash with your pen light. Carry your pen light in the emergency room, especially on trauma surgery rotations. Carry a pen light always. Carry a pen light and like 3 pens because the nurses are going to start to you can also use this opportunity to check not only for like for them following commands, but also for like a very, very brief neurologic assessment. So can you move your left and right ankle up and down, move your right ankle up and down. Can you like bend your elbows real quick? You establish that they've got limb control in all 4 extremities, right? So like there's unlikely to be like a massive spinal cord injury if you can move like all 4 extremities voluntarily, right? If they can't do any of those things, this is not the time to kind of unlock exactly whether it's an anterior cord syndrome or if it's Brown-Séquard or any of those other things. This is just an opportunity to be like noted, minimal movement on the left-hand side or something like that, and then you'll call that out to the trauma team. Unable to range left lower extremity, okay? So GCS whatever, alert and oriented, pupils Pearl, able to control all 4 extremities. That's what you call out for the trauma team. Okay, let's do Glasgow Coma scale. What are the 3 categories of Glasgow Coma scale? Motor, eyes,
verbal,
speech. Yeah, or verbal. Yeah, so eyes, verbal, motor, speech. You can call them verbal, speech, motor, movement. Yeah, and then eyes are eyes. Eyes 4. So what is verbal? How many points is verbal? 5. And what's motor? 6. How much does this table get? 3. Yep, table gets 3. Even the most untunded, unconscious sack of bones gets a 3. Okay, so everybody gets a 3. This is how I evaluate Glasgow Coma scale. Eyes, are they open already? So if the person wheels into the room and they're like on the C-spine and they're looking around like that, I've already assigned them a 4 on verbal because their eyes are open spontaneously, right? Or do they open their eyes when you ask them? A lot of times people are coming in, they're like, oh my God, what's happening to me? Oh my God, oh my God, oh my God, oh my God. And they have their eyes closed and they're like, breathe, just breathe. They're doing some sort of weird like meditation. But if you're like, hey, Annie, can you open your eyes? And she opens her eyes. 2 for 1. You've established she's obeying commands and she can open her eyes to speech, right? Verbal, what's your name? What happened? Like we did earlier. And motor, can you give me a thumbs up on your right hand? If they can, or on the left hand, then you know that they're following commands. Okay? You can also do squeeze my fingers, or squeeze my hands. Can you raise your arms? whatever like kind of fits for the situation. They have like bilateral like, radius ulnar or like displaced fractures. Maybe raising their arms is not the best choice. You can wiggle their toes. You can have them bend their ankles. You can have them blink their eyes, open their mouths, look at you, that kind of thing, right? Try not to do anything that would cause them to disturb their spinal immobilization. That's kind of bad party favor. Okay? All right. So, E is exposure and environment. Exposure, everything's off. Everything comes off. Carry trauma shears, good ones. The kind that can cut through a penny. They really can. They really can cut through a penny. It's kind of hard though. It's pretty hard to get through a penny. It takes, and then your trauma shears are basically ruined. So don't do that. But you can't you should carry like some or at least know where some good trauma shears are, because that's something that you guys can help with trauma assessment. And when I say everything comes off, everything comes off. So motorcycle boots need to come off, motorcycle suits, leather jackets. Most of the time EMS is going to take care of helmets for you before they get to the emergency room, but helmets need to come off. Everything needs to come off, no matter how much the patient hates you afterwards. Because I've been cussed out by a lot of motorcycle riders who are like, are you seriously going to cut this like $900 leather jacket off of me? And I'm like, yes, I am, sir. And you can try to preserve, like say, like motorcycle leather boots and stuff, like if it's possible. But you can't do anything that's gonna cause them to be doing a whole bunch of twisting and moving. So that does absolutely limit your options as far as like how you can remove things without cutting them. Yes.
So you have a football player comes on with a football helmet, right? You guys have like a quick release in the ER, or you guys just share like cut through?
Most of the time we have some form of like kind of quick release, or they have like a small saw or something that they can use to cut it off. You can also, there is, especially like in Tim's helmet, I think it's in there, there's like a helmet removal technique that allows you to sort of maintain C-spine while still removing like a football helmet. It requires a couple of people. But most of the time EMS does that for you. They're trained in that. They both EMTs and paramedics receive training on removing helmets. So they should generally remove helmets before you get to the emergency room. Not always, but most of the time. Good question. But pads have to come off, so football pads, you're cutting right through the football pads. Everything comes off. Nothing should, you should never delay care to try to remove something, basically. So if you're trying to manipulate this motorcycle boot off of this obviously deformed ankle fracture, just cut it off. You're going to be at it for an hour, and you need to move on with the assessment. So it's unfortunate. I do not take pleasure with cutting people's expensive things off. I've had women come back and be like, that was my best bra and I will never find another one like that. And I'm like, sorry, but I did save your life, so that has to count for something. And they're like, no, not my life is worthless without the bra. Okay, and then environment, you're avoiding hypothermia. Hypothermia is not just something that happens when they are frozen and stuck on Mount Everest for 3 days. Hypothermia is something that absolutely can happen in trauma bay. So, to that end, you personally will be sweating in the trauma bay because it's kept warm for the patients. You will make sure that you cover them with blankets as soon as they have their clothes removed. For obvious reasons, not only do you want to preserve their modesty whenever possible, because the trauma assessment is pretty invasive, but you also want to make sure that they stay warm and covered, okay? Any questions about any of that? Okay, so this is a note about taking a history in trauma patients. Whenever possible, do a thorough history. It's not always going to be possible, but do everything you can to try to get a thorough history out of a trauma patient. Thorough history should not delay care. So, for example, you're not going to be like, hang on, I'm just going to stay here and we're going to hold the CT scan while I talk to them about their family history and what kind of housing situation they have. But there's lots of opportunity when you're walking to the CT scanner, when they're getting packaged and stuff. You can fire off these questions real quick while they're waiting to be moved. Obviously, if they're completely out of it, you're not going to be able to ask them questions. But if you have an opportunity to, this may be one of the only chances. For example, they decompensate and they lose their lucidity, like they become unconscious or altered, this may be the only opportunity that you have to ask some of these questions. So try to if you get a chance, okay? So that's history, allergies, meds. You especially want to ask about blood thinning medication, especially if there's a suspected head injury or internal bleeding. You want to ask about past surgeries, specifically thoracic and abdominal past surgeries, because that may affect our surgical management on this day if they need to go for trauma surgery or something like that, right? And then we always ask them, do you smoke, drink, drugs? I also ask them, I try to ask them about like end-of-life care, like advanced directives, pulse, those kind of things, especially if they're older. Because it may, again, maybe one of the only opportunities that you have to ask them about what their wishes might be if they decompensate. So don't say that, because they get really upset when you're like, we're gonna die? And you're like, no, I just need to know like what you would want if you were gonna die. When you talk about smoking, drinking, drugs, so you ask them, do you smoke tobacco or do you use tobacco in any other form? So that's including like snuff, which is still out there, believe it or not. It's not just for the 1800s anymore.
Who sells that?
And chew tobacco, also a very popular choice, which is surprising because it's kind of low. But, it affects everything. Drinking, do you drink alcohol? And drugs, think about how you're asking about drugs. I usually say, do you take any drugs not prescribed by a doctor? Like marijuana, cocaine, methamphetamines, heroin, PCP, or anything else. And if they're like, oh yeah, methamphetamines, then you ask them, how do they take it? So how do they ingest that substance? Do they smoke it, snort it, inject it, pop it, something else? And even if it's not like directly applicable to the specific drug, I still just list like all those choices and let them kind of choose one. That way you know, are they an IV drug user? Like, because you can inject like more than just heroin, right? Or are they skin popping? Are they at risk for MRSA infection? So are they already MRSA positive because they've had skin infections? Are they snorting or like smoking it? Are you worried about like, like lung inhalation issues, that kind of thing? Also ask them when was the last time they did it. So a lot of people will be like, like take a look at their watch and they're like, oh, like 30 minutes ago, right before the car almost ran me over or something. But it's important because you need to know like how that may be affecting like their vital signs and how that may be affecting their future mental status of their condition, right? And then housing, if I get to housing, it's a good day. And if I usually say something along the lines of, do you have somewhere to stay when you leave the hospital? That way it kind of gives you an idea of like what kind of housing situation they're dealing with. If they're like, yeah, I have a house, and you're like, great, problem solved. But if they're like, well, I've been staying on my friend's couch, red flag, put it in the chart, make sure that like social work is contacted because they're going to need to know that when they start talking about placing the person when the person's discharged from the hospital. And if they're like, nope, I don't have anywhere to stay, I sleep on the streets, also red flag, then you really need to get social work involved so they can figure out what they're going to do, how they're going to help this patient manage outpatient recovery and treatment. Okay, so resuscitation we're going to talk about a lot more in the coming weeks, but basically we start with IV fluid crystalloids. So that's 1 to 2 liters of isotonic crystalloids. Or with pediatrics, an IV bolus of like 20 cc's per kilogram. We may also consider things like colloids or blood products, but we're gonna unlock like a lot of this like next week when we talk about IV fluid resuscitation. And there's like kind of a lot to talk about there as far as like what we end up choosing and what the pros and cons are of each choice. So in general trauma assessment, we just start with the crystalloids, 1 to 2 liters. And we always use warmed fluids in trauma whenever possible. So we're gonna run it through like an IV fluid warmer, or we usually actually have it like in a warmed, like a blanket warmer. We keep IV fluid lined up so that they're getting warmed IV fluid and not contributing to hypothermia. When we talk about radiology and diagnostic studies, where I worked, we did chest and pelvis on just about everybody at bedside. So they get a quick chest, a single view chest x-ray, single view pelvis before they even go to like CT scan. We almost never do C-spine radiographs. They're basically like just extinct as far as management of C-spine fractures in the acute trauma setting. But we do pan scan like CT, so CT head, CT C-spine, CT chest, abdomen, and pelvis. A CT head with or without contrast? Without, yeah. So CT head is almost always without contrast unless you're looking for something specific. What about CT C-spine? Without. So they usually do head C-spine, and then they do the contrast administration, and they do chest, abdomen, pelvis, because that's all going to be with contrast. Okay. When should you take the time in the initial survey to do extremity X-rays? Who knows? So extremity X-rays, so like lower extremities, upper extremities. When would you take the time in the initial assessment to do those? Yeah, so if you have like neurovascular compromise, then you're going to be doing X-rays as part of this initial assessment on whatever the affected extremity is. Then you're likely going to be reducing it bedside before they even go to like CT scan and then re-X-raying. So that is basically the only time that you'd be using X-rays before you go to CT scan. Because after the initial assessment, they get packaged, off they go to CT scan, and then they come back, and that's usually where we do like all the extremity X-rays after they have been like initially evaluated. So they've had like their CT scan. And as far as like what you are choosing for CT scan, it depends like kind of on like what you find and what you suspect like the mechanism of injury to be. So this is something where like provider judgment becomes like very important. A lot of trauma surgeons will differ in their opinions on this, and there's like 2 trauma complexes in the United States alone that kind of disagree about this. So pan scan would be CT head, CT C-spine, chest, abdomen, pelvis. That's commonly used indiscriminately when there is an extensive mechanism of injury. So if there's like a high velocity collision, if you have like an auto versus pedestrian, you're generally just going to pan scan them even if they're not complaining of neck pain or chest pain or something like that. Or you may be a little bit more choosy if it's a slightly lower velocity mechanism of injury, or if they have a kind of an isolated trauma source, then you might be a little bit more choosy, like just chest, abdomen, pelvis or something like that, or maybe just head and neck if they have like nothing going on with the torso, that kind of thing. But that's sort of a provider judgment call.
Could you repeat for me, like it says, when do you take the time in the initial assessment to check the extremities? Was it X-ray the extremities?
So you're only X-raying in the initial assessment if they have neurovascular compromise. So if they have like a fracture, like an obviously dislocated fracture, that will require immediate reduction in order to reestablish blood flow or neurovascular exam, then you're going to be doing X-rays there. Any other questions so far?
So pants with the pelvis abdomen.
So pan scan is head, C-spine, chest, abdomen, and pelvis. So the whole thing. Pan meaning broad or all.
Oh, okay.
So that's what they mean by pan scan. Pan, yeah, like pan,
I heard that
like
too.
pan, or you would fry something in, but also pan means like global, essentially, yeah. And then you may throw in other things like an extremity CT scan or something, depending on like what you know or suspect. Like a lot of times we'll throw in an extremity for like extremity stab wounds because we're looking at like the vasculature. Or if we have like a severe fracture, we might throw in like an extremity CT scan that will allow us to look at like vasculature. We do that for like partial amputations, like in motorcycle collisions, that kind of thing. Okay. Any questions so far?
Why don't we use contrast on the C-spine?
What?
Why don't we use contrast on the C-spine?
Because we're looking at, we're not looking at vasculature mostly. So you can do a C-spine or a CT neck with contrast. That would be for something like a neck trauma, like a direct penetrating injury or a blunt trauma to the neck. But in general, when you're doing the C-spine, you're looking at the bones. And so the bones, you don't want or need contrast for the bones. You want that, same with like the head, you're not looking You're looking at the vault of the skull and also like any already present bleeding. So contrast is gonna cause problems with that. Yeah. And that's like a whole class. I would love to wax poetic about CT selection, but yes. Okay, so what's the most common cause of shock in a trauma patient? What's next? What's next? You guys catch on fast. And then maybe some other stuff. So basically in a trauma patient, you are going to assume massive hemorrhage until proven otherwise. And even if you can't see it on the outside, they're bleeding from somewhere. So where do trauma patients lose a life-threatening amount of blood? Okay, I hear pelvis, I hear abdomen. Where else? Where else in the body can you lose a lot of blood? Huh? Who said what?
She said thorax.
Thorax? Okay, so chest. Yep. So chest, abdomen, pelvis we've got so far. Where else?
Femoral vein. I mean, yeah, you know.
Yeah. So long bone cavities, especially like the femurs. You can lose a lot of blood into the thighs. And what's the last one? No neck. Stop pointing at your neck. What? What, brain? No, you can't lose a life-threatening amount of blood into the brain. You can cause other problems in the brain, but not a life-threatening amount of blood.
You wanna kill someone? Like,
But if you're cutting, you're like shaking someone in the neck, right? Where are they going to bleed onto?
no.
Not right into the neck. They're going to bleed externally, right?
Yeah.
So we have chest, we have abdomen and pelvis. We have long bones. There is one other that there's two, these last two are the ones that you guys didn't quite hit on, and they're the most common to miss, so these are the ones to kind of keep in mind. The retroperitoneum, you can lose a life-threatening amount of blood into the retroperitoneum, and you can lose a life-threatening amount of blood into the street or onto the street. So that's what I mean when I say like if you like slice someone's neck open, they're not bleeding into their neck, right? They're bleeding onto the street, and they're going to lose a life-threatening amount of blood that way. Or they're going to, not necessarily the street, but wherever you have sliced through their carotids, that's where they're going to bleed, right? Okay, let's talk about hypovolemic shock real quick. We're going to hit shock pretty hard like next week. So this is just kind of a brief primer on hypovolemic shock. This is how I like to break down the categories of hypovolemic shock. Think about it like a game of tennis. Love, 15, 30, and 40, and game over. So love is pre-shock. So like before they even like reach a stage of shock. So that means they've lost like less than 10% of their blood volume. Okay, and that's going like pretty well, right? Things are pretty good. Still very winnable game of tennis if you've got a love score, right? If you've got a class 1, this is 15, so 10 to 15% of their blood loss. They're pretty well compensated. Maybe a little bit of minimal tachycardia. Still okay. Starting to suck a little bit, but you could still win that game of tennis, right? Class 2 is 30, so that's going to be 20 to 30% of their blood volume. They've definitely got tachycardia at this point. They've probably got a narrowing pulse pressure, and they probably have a fair amount of anxiety. Okay, this is going to be tricky. And class 3 is 40, so they've lost 30 to 40% of their blood volume. They got tachycardia. They're starting to get hypotensive. They're not urinating anymore. They're pale, cool, diaphoretic. They're confused or attunded, otherwise altered mental status. Ooh, this is starting to be like a kind of game of tennis you're probably not going to win, right? And then game over. So that's going to be class 4 and higher. So it's greater than 40% of blood volume is lost. They've got end organ dysfunction and it's imminent death. So that's going to be unlikely that they're going to have a meaningful recovery after that point. Make sense? Okay. So, once we've done all of that, then we're gonna do our secondary assessment. This is your head to toe, your more thorough exam. So, basically, the ABCDE takes about 60 seconds, up to maybe 2 minutes max. So you just go boom, head to toe, real fast. Everything you're doing is like super fast. It might take a little bit longer if you're doing interventions, so if you have to intubate somebody, or if you have to do like a needle decompression or a chest tube or something like that, then you might take a little bit longer because you're fixing life threats. But if everything's normal, you should be able to blow through that in about a minute, maybe 2. Okay? Then your secondary survey is going to be a little bit longer. So this is going to be, I start from the very top of the head, work my way all the way to the toes. So when we talk HENT, we're looking at the head, we're palpating the skull, where you kind of slip your hands underneath the base of their head and pull them out and see if you've got blood on your gloves. Because you don't want to miss a bleed, like a scalp bleed on the posterior aspect or the occipital lobe. You want to make sure you look in their eyes, you look in their ears for like hemotympanum. That can be a sign associated with some skull fractures, so we don't want to miss that. You want to look, in their nose, you want to look in their mouth and in their throat. You're looking for palpating for facial fractures, so you palpate the whole entire bony structure of the face and make sure everything seems intact. And you might check like kind of visual acuity or like rough visual acuity. Chest, start like we usually don't do much with the neck in the secondary survey because we're waiting for other films to come back so that we can clear them clinically from C-spine, or we are waiting for them for their mental status to improve so that we can remove their C-collar. Okay, so we usually kind of like, we'll palpate the bony bodies along with the back of the neck through the C-collar, but no C-collars get taken off in the initial or secondary assessment. Make sense? So chest, come down, palpate the whole clavicle, work your way along the clavicle, work your way along the sternum, and then give the ribs a quick push along the sides. This is also a chance to auscultate again. And then you move into the abdomen, palpate and auscultate all 4 quadrants, do a FAST exam. That's ultrasound. And we're going to talk about FASTA in a couple more slides, but that's one of my favorite topics of all time. When you do a pelvis exam, you're doing a single rock for instability. So what happens if you rock the pelvis and the patient is like, please stop, oh my God, it hurts so much. Do you call all your friends over and you're like, hey, look at this guy's pelvis is unstable? Or do you just call it a day? Call it a day. Right, 1 rock for unstable. So you should be able to feel, when you press in and down, you should be able to feel whether the pelvis moves in a way that you don't expect or whether it remains stable. Extremities, range all the extremities, look at all the extremities. For any injuries, bruising, etc. Consider tetanus prophylaxis, and if you have suspected intracranial pressure elevation, then you may consider like hyperventilation, mannitol, or elevating the head of bed, but only if they're not still attached to like a longboard, because you can't elevate the head of bed if they're still attached to a giant longboard, right? Or if they have pelvic fractures and you don't want them to be like bending at the hip, then you might not elevate the head of bed. Let's see. And then we are going to flip the patient. So don't ever forget the back side of the patient, because now we've looked at the front basically twice, right? And we have never seen the back side of the patient. So you're going to, this is where like you're going to be able to move the C-spine board. You're going to have your whole team maintain C-spine precautions while you log roll the person up to the side, palpate all the way down the back of the spine. Does it hurt here? Does it hurt here? How about now? How about now? How about now? How about now? The patient's like, dear God, no. But you have to palpate every spinal level so you kind of know what you're dealing with. Then you're going to check rectal tone. So how do you check rectal tone? Yeah, digital rectal exam. Also called the Harborview handshake. That's where I came from. Everybody got it. Hey, how are you? Welcome to Harborview. So basically, every patient gets a digital rectal exam or an evaluation for rectal tone. Now, if the patient is like 120% like stable, everything's totally fine. There's like a low speed like vehicle collision. something like that, or an isolated extremity trauma. What you can have them do instead of subjecting them to the Harborview handshake is you can have them squeeze their butt cheeks together. Same kind of set of nerve. So if they can clench their butt cheeks together, they have good rectal tone. But if you have a person that has any sort of pelvic trauma, any sort of abdominal trauma, any sort of genitourinary trauma, or is at all altered, obtunded, or otherwise like not 100% themselves, they get a digital rectal exam. Okay? One of the most common injuries to miss with like severe pelvic fractures is rectal injuries. So you really need to do that rectal exam. Make sure you're not missing something like that. Any questions so far? Okay. Okay. Head trauma. What are we looking for in the physical exam? What are some things that we are looking for when we think about head trauma?
Pupils.
Pupils, good. What else?
Nervous response, just facial expression.
Yep, like, so they're, just their overall, like, kind of mental status, right, their GCS score. What else? On physical exam, what else are you looking for?
Bleeding from the orifices.
Bleeding from the orifices, so hemotympanum, bleeding or like fluid leaking from like the nose, or mouth, any like mouth injuries, mouth or nose, like facial injuries, so you want to think about those as well, loose or broken or missing teeth. Those are all important. What else? Got missing teeth. What else? Any other questions? Any other thoughts?
Your breathing.
Yeah, breathing. Yes, we're going to look at breathing. Like we're going to look for like Cushing's respirations or something like that, which we're going to talk about in a minute. Also looking for periorbital ecchymosis or bruising behind the ears. Does anyone know what that's called? What those things are called? So mastoid ecchymosis. What's that called? No, mastoiditis is Okay, so this is called a battle sign. When you have mastoid ecchymosis, it's called a battle sign. When you have periorbital ecchymosis, in the case of trauma, it's called raccoon eyes. And these are late signs, so you are unlikely to see them, but it's still important to kind of like think about. They're late signs of a basal skull fracture. So that's going to be like a base of skull fracture, and that's going to be like a pretty high mechanism of injury, or pretty like high velocity or like severe mechanism of injury. So that's a little bit harder to break than other things.
You don't check like step off and stuff like that.
Mm-hmm. Yep, that's going to be like neck. When you do like palpations or when you do spinal trauma, you can look for step offs for sure. We're going to do that in a minute. Okay, so remember that the scalp is like 5 layers and it's very highly vascular. So you can lose a lot of blood from the scalp, actually, a surprising amount of blood from the scalp. So one of the things that we'll often do, like in secondary assessment, is we're going to staple up scalp lacerations, kind of like right there, just to get them out of the way. The only time we don't do that is that if we have like periosteal like disturbance or something like that, then we're not going to close it until we have a chance to close that layer. Okay. So I put the Monro-Kelly hypothesis here. Has anyone heard of this? Okay. So basically, this is saying that like the head is like a closed system. So the brain, blood, and CSF within the skull have to remain the same. Otherwise, bad things will happen, basically. Okay? So anytime you have some sort of disturbance of one of those things, you're going to disrupt the Monro-Kelly hypothesis, or the Monro-Kelly kind of balance. And then you're going to end up with problems, likely herniation. So basically, like if you have like an increase in blood in the brain, then something else needs to go out. Either CSF or brain needs to go out in order for that volume to remain constant. CSF would be preferable, but it's more than likely going to be brain, because the brain is going to start to herniate out through whatever hole it can find. So what is the reflex called when you have like start of like herniation? I said it a little earlier, I can't give it away. What? Cushing. Yeah, so the Cushing reflex is what happens when you start having like herniation. This is a picture of the Monro-Kelly hypothesis. You can see like there's 80% brain, 10% blood, 10% CSF. If any of those change significantly, something else has to be reduced in order to maintain that constant balance. And then this gives you an idea of all the different types of herniation that you can have. The most common is going to be uncal. So uncal transtentorial. So it's going to be coming out through the base of the brain, the brain stem. The brain is going to be like kind of pushing out of the foramen magnum. Okay? And then this leads to that ipsilateral pupil dilation on one side. That's what causes that like unequal pupils that kind of are a classic finding for like for intracranial hemorrhage, right? Yeah.
I'm sorry, I didn't finish that last part.
So unequal pupils
Oh, okay.
is being caused by herniation in most cases, and that's because the brain is compressing the parasympathetic fibers of the oculomotor nerve, so cranial nerve 3, and so it's causing like unopposed, like a lack of opposition for the sympathetic nervous fibers. Okay. So we talked about this a little bit already, but this is going to be your CTC spine to evaluate for injury, and these are some of the indications for like CT head. Basically, like anybody who has a significant mechanism of injury, or is at all altered in any way, shape, or form, they win themselves a CT head and C-spine as far as I'm concerned, generally. So we're pretty liberal with the application of CT scans, more so than you'll see in like less severe environments. And that's because we really don't want to miss any of these kind of like severe trauma mechanisms of injury. Make sense? Oh, and then also worth noting, the recommendation is to not delay imaging for combative or uncooperative patients. So if they're combative, uncooperative, they won't lie still for the exam, you can't even get them to the CT scan or whatever it is, intubate. Intubate, sedate, and off they go to the CT scanner. So it's not worth fighting with them about it. You can try sedating them first. If that works, great. But if that doesn't work, you're just going to go ahead and RSI, like rapid sequence intubate them and send them to the CT scanner so you can get your images. Because that's what you need to do. There is a protocol, the Canadian Head CT protocol. Has anyone heard of this? This is used more in the emergency room than it is in trauma surgery, but it can help direct whether or not you need imaging and whether or not the person is likely to need like neurosurgical intervention. But we don't spend a lot of time kind of like chewing the numbers on this. We usually are more likely to just sort of image and ask questions later. But it is 83% sensitive for the identification of like an intracranial lesion, so like any sort of like intracranial bleeding, and it's like 100% sensitive for patients that need neurological intervention. So if they are meeting this like Canadian head CT protocol, then they're likely to need neurosurgical intervention. This gives you an idea of some of the skull fractures. I'm not going to get into this a ton, but like I said, the basilar usually is a significant mechanism of injury. A depressed skull fracture has a greater chance of having an underlying brain injury for obvious reasons, right? If you have any skull fracture that is open, depressed, involving a sinus, like so you see it on CT scan as involving a sinus, or having pneumocephalus, which is like air inside the brain, then you need to give antibiotics as part of your initial trauma assessment. Okay, usually Bank or ceftriaxone or both. Okay, so let's talk about concussion. briefly. So we're not gonna get into like full like head trauma management, like all of the deep specifics of like severe head trauma. But I think concussion is specifically worth mentioning because you'll see it in the emergency room as well. So a concussion is a mild traumatic brain injury. And it's important to recognize it as a TBI. It is not just a concussion. There's significant possibility for fairly like moderate to severe like post-concussive syndromes and other things that can happen after a concussion. And so it's important to take them seriously. The important things here are that you usually have a kind of amnesia and confusion. You might have a transient loss of consciousness or a reduction in level of consciousness. And then the CT head is usually normal. So usually you don't see anything on the CT head. There's a whole, I actually have it on the next slide that's going to pop up. There's a whole thing for returning to activity for sports now. The big kind of like hot button like phrase or hot button diagnosis for like sports players, especially like football and things like that. There are definite increased like morbidity from multiple incidents of concussion. So they're much more likely, the more concussions they experience, to have like lasting changes in like consciousness or mental status, and also more likely to have more severe outcomes after like the first, second, third concussion. Their chances go up kind of exponentially. So this is just for your own edification. We're not going to go through this extensively, but this gives you an idea. It's kind of a stepwise approach for returning to sports or activity, and each step must be passed before they can proceed to the next step. So if they don't pass one step, they go back to the very beginning. Do not pass go, do not collect $200, go down the chute on the chutes and ladders or whatever you want to call it. But that was a great game. I love picking, that's what good at it. I love things that I'm good at, basically. And then also, like, so a lot of concussion patients will be discharged home from the emergency room. It's very important that we as providers, we are giving them appropriate return precautions for concussion. So at any point they get a worsening headache, they start developing like worsening neurologic symptoms like dizziness, they have vomiting, unequal pupils, confusion, anything like that, they need to go right back to the emergency room. They need to get another CT head. They're likely to be admitted for observation at that point. Okay.
Sorry, Dr. Thompson, I missed the part your antibiotic prophylaxis. You said depressed open.
Depressed, open, involving a sinus. So if you get a CT head back that shows like the involvement of like one of the bony sinus walls, or if you have pneumocephalus, so air inside the brain cavity. Yeah, CT heads are always with contrast. Even when you're just looking at the skull, it's gonna, without contrast. Without contrast, yeah, my bad. Without contrast. Anybody heard of DAIs or diffuse axonal injuries? Anyone heard of these? So we actually saw these like kind of a lot in trauma surgery, and they're like devastating. It's really sad because a lot of times it's like very young people. A lot of times it's young men in like high-speed motorcycle or car accidents, and these are basically like the neurons are like microscopically sheared from like a coup contra coup like effect from like blunt trauma. So this is not like a direct trauma, but yeah.
Is a contusion from a concussion?
So contusion is different from concussion. So a concussion causes no actual like brain damage that is visible. A contusion will be just a but it's basically a bruise of the brain. But it is a lower level than like a head bleed, which is where you have like an intracranial hemorrhage of some kind. And we're going to talk about those in a minute. Does that make sense? Okay. So often DAIs are quite obtunded. So they require intubation, they require ICU stays, they're often combative, impulsive, their recovery is slow if it happens at all. So a lot of times they go from being like a normal walking, talking young adult to being in diapers and bedbound for the rest of their lives. And I gave you a picture of kind of like what it looks like. So you can see that you have like, basically the axon is disrupted or sheared off. And then there's like often like kind of synapse damage as well. And then the axon kind of starts to swell, and eventually it degenerates. And so that's why the damage is long-standing. So it is not something that is easy to recover from. Sometimes they have some level of meaningful recovery, but it's unlikely that they'll have a complete recovery, where they will return to exactly where they were before. So, oftentimes the head CT, the initial head CT in these patients will be normal, and it's only with like an MRI later that you will see changes in like the structure of the brain that lead you to believe that it's been a DAI. So these are kind of like unexplained, like level of consciousness changes, but most of us at that point have established like it's not other things that might cause mental status changes like electrolyte abnormalities, drugs or alcohol, other types of head injuries, that kind of thing. So it's going to be likely to be DAI at that point. Rapid. Oftentimes by the time they get to the emergency room, they've got something going on, and then they just fail to recover, basically. So you'll see a lot of people that are kind of like confused, they got their bell rung, but like by the time you check on them that night upstairs, like if they come in at like midday, by the time you check on them at night, they're like, whoa, that was a crazy day, but I feel a lot better now. Because like whatever maybe was in their system has worn off, the shock has worn off, and they're kind of able to sort of process the events, and they are like then alert oriented. DAIs, you will never have like a lucid interval like that. So you'll never have them be like, wow, that was a crazy day, and then they'll get like worse. They just will never improve. Their mental status will stay the same. Okay, epidural hematomas. So this is a collection of blood between the dura and the skull. So what is tearing? Yeah.
Can we have a little break?
Oh, is it time for a break? Yeah. Fine. Yes.
I guess.